Dr. Casey, and it's my privilege to make the introduction today for our grand rounds. Um, First of all, an item of business. At the conclusion of Dr. Huang's talk today, Dr. Juan Paul Galindo, Dr. Cara Curry are going to present some information on a project they've been working on, and they request that at least the residents stick around at the end. I'm sure they'd be happy for anybody else to stick around too. They're going to present some of their findings, and so they can give you the details on that at the conclusion of Dr. Huang's talk. So our speaker today is Dr. Haojiang Huang. Dr. Huang earned his medical degree from Beijing University. It also has a PhD in neurosciences from the Indiana University, and that makes him uniquely qualified for the particular topic that we have today, as I'm sure will become clear. He did some training in anesthesia prior to coming to his senses and deciding to become a psychiatrist instead. I hope there are no anesthesiologists here in the audience. He served his residency at Case Western, served as an assistant professor of psychiatry at Southern Illinois University. It's been our privilege to have him here at U of L as assistant professor and director of inpatient psychiatry at Norton within our department since 2013. And his topic today will be Charcot and Hysteria, reflection on the delicate physician-patient relationship. So let's welcome Dr. Huang.
All right, thank you, Dr. Casey. And all right, so the topic of my talk today is Charcot and Hysteria. And the last time I gave a grand round, the topic was on placebos. So this time, I decided to talk about hysteria. And then the original title was Hysteria and Charcot. And I've since changed it to Charcot and Hysteria, but it's still too broad a topic. I hope, this talk don't last too long. And so it's a reflection on the delicate relationship, physician-patient relationship. And so the goal and objectives. So I want to briefly review the complicated history of hysteria and then investigate Charcot's mistakes in hysteria and explore different meanings assigned to hysteria throughout the years and discuss the physician-patient relationship in psychiatry and what should we do about it. And the real question I'm trying to answer is, how come on 6 East, all my patients come to me, most of them come to me, say, I'm suicidal, homicidal, I'm hearing voices, I'm paranoid. So there are a lot of synonymous names, for hysteria, such as hysterical neurosis, conversion disorder, somatoform disorder, psychoform disorder, dissociative disorder, post-traumatic stress, psychogenic disorder, functional neurological disorder, and medically unexplained disease. And this definition is from DSM. So dissociation is a disruption and a discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. And so for me, everything always starts with a clinical case. So this is a 42-year-old Hispanic female with a previous diagnosis of bipolar disorder, pseudo-seizure. She came to the ER with seizure-like activity. She was given Vimpat in the emergency room and admitted to medicine. Neuro was consulted. They saw a seizure-like episode and believed it to be non-epileptic in nature. And then they did EEG. They didn't find any epileptic form, and Depakote level was therapeutic. While in the emergency room and on medical floor, patient believed multiple people are trying to kill her, including medical staffs. And then psych was consulted. The patient relayed to them she was seeing a man at the foot of her bed who was trying to choke her. She did not recognize her. Patient attempted to escape twice while she was on the medical floor. She attempted to wrap a cord around her neck, and then she was transferred to 6 East. At interview, patient was agitated, appeared scared. thinks she's not safe, endorses auditory hallucination of a man's voice, which says, you need to finish with your life. She doesn't know this voice, states it's a policeman, states the man is sitting next to her on the bed, became upset when staff told her he was not real, reports hydroxyzine, help with anxiety, as well as Latuda, and then she asked if she can go outside. She was worried this was jail. And then she was in Norton with a previous admission with similar presentation. And past psychiatric history, the diagnosis of bipolar disorder. She was diagnosed in Cuba at age 18. She was treated as inpatient in Puerto Rico, had 2 previous admissions for depression and suicide attempts. The past medication includes Depakote, Latuda, hydroxyzine, but she hasn't taken the last 2 for several months. And then she had a suicide attempt at age 18. Social history, she was born in Cuba, moved to Puerto Rico, and then came to Louisville 5 years ago. She's been married for 25 years, had no children. She works as an accountant. She graduated from high school, has some college education. There's no religious affiliation. And she reported the stressors, including stressful work environment, concerns about her mother who's in Cuba, who's going blind. And hospital course, so she was put on 1-to-1 because she would frequently become agitated, try to escape, thinking we were trying to harm her. Endorsed auditory visual hallucination of a policeman who told her that we were trying to hurt her. So we restart her on Latuda and Depakote. And then early in the hospital stay, we feel like we were treating depression with psychotic features rather than bipolar disorder. So we discontinued her Depakote, start her on Zoloft. And also hope that will help her with her anxiety. We plan to do ECT for her, and then we even obtained consent from a Spanish interpreter. But patients seemed to get worse when more treatment was offered. So on June 21st, she complained of squeezing chest pain, racing heart, start forming at her mouth, start having seizure-like activity. Intermittently, she would open her eyes, ask us what's happening to her. Initially, she had some wheezing, which resolved, and she has erratic breathing, but she would obey orders to take deep breaths. Her pulse ox was 90 to 100. Her systolic blood pressure is in 140. Heart rate got up to 120 to 140. And the EKG was done, shows sinus tachycardia. And Ativan 2 milligram IM was given with effect. And later, she started to have tonic-clonic activity when we tried to draw labs. And the patient keeps saying we were trying to take her blood because we were trying to kill her. Because medicine was already consulted for ECT clearance, and then because her current tachycardia and high blood pressure, she was transferred to medicine. At that time, all labs were normal, including cardiac enzyme and D-dimers, and then she was started on aspirin, antihypertensives. She tried to escape from her sitter on medical floor, believed her life was in danger, so she was transferred back to 6 East. And then, in general, she seemed to have no recollection about some of these events. She doesn't remember running down the hallway, and on the 24th, she complained of dizziness, and then quickly escalated during morning runs. She had a seizure, and then became so agitated, she beat a nurse, was placed in restraint. And so she kept yelling, "Please don't kill me." And then later she denied she beat a nurse, and she was even restrained. However, a day later, she asked the Hispanic nurse why he hurt her during the restraint. And at one point, when her husband came to see her, she said the husband was her brother. And then the patient admits to depersonalization, derealization, complaint of nightmares, social isolation. She reports at times she feels like a different person. She also complained of anxiety, so we start her on Klonopin and Prozocin. So at that point, we told the patient if she continued to have these dissociative episodes or acting out, we would have to send her to Central. and she didn't want that. So after that, she no longer had any outbursts. She stated the policeman went away because we all told her we're not trying to hurt her, and then she was off one-on-one. She did well. Her symptoms seemed to got worse when more clinicians are around. After 2 good days with no episode, we feel comfortable to discharge her. The husband agreed she was at baseline, and then she appeared much happier and calmer at discharge. So this is a summary. So overall, this is a challenging case. It was difficult to discern what exactly was happening during this episode and how much control she has over them. That's actually a very good question. And then because the episodes are characterized by excessive emotional reaction, derealization, depersonalization, and having no memory of events afterwards, we came to the diagnosis of dissociative disorder. We also concerned some culture-bound symptoms such as tachycardia nervous, and her pseudo-seizure are likely conversion disorder, and so this possibly happened with patient with traumas, and then patient consistently denied what she had ever had trauma. It is possible the policeman she was seeing is a flashback. We suspect there's some trauma in the past, and then in later admission, patient endorsed, she was physically abused by her father in Cuba. And but actually the most important exchange happened during all these exams. Not there yet. Okay. So the admission diagnosis is bipolar with psychosis. And then this is our discharge diagnosis. Dissociative amnesia disorder, conversion disorder with pseudo-seizure, depression with psychotic features, and anxiety and OS. And so my question is hysteria a better diagnosis? And so why do I say that? So one day, during all this excitement, and I had this exchange with my resident. So I said, this patient is hysterical. And then my resident tell me, we don't use that word anymore. So I was like, what's going on with this? So is this some sort of censorship? I grew up in communist China. I should know, if there's censorship. And then did she just call me a misogynist? And is she trying to save my career? So God knows, how much trouble I have with my career. But I hope, after this talk, you realize it's definitely worth saving. Okay. So what am I going to do? So I'm going to give a grand round. Okay. So that's where we are. All right. So, but all joking aside, and then I found a really serious reason why I need to talk about this. So I found it in 1984. So supposedly this book became more popular recently, and so in the appendix to 1984, George Orwell wrote this principle of newspeaks. So the purpose of newspeak was not only to provide the medium of expression for the worldview and mental habits proper to the devotees of English socialism, but to make all other mode of thoughts impossible. It was intended that when newspeak has been adopted once and for all speaks forgotten. So a heretical thought, that is a thought divergent from the principle of insight, should be literally unthinkable, at least so far as thought is dependent on words. Its vocabulary was so constructed as to give exact and often very subtle expression to every meaning that a party member could properly wish to express, while excluding all other meanings and all the possibility of arriving at them by indirect method. This was done partly by invention of the new word, but chiefly by eliminating undesirable words, and by stripping such words as remained of the unorthodox meaning and so far as possible of all secondary meaning whatsoever. So words are important, and then if you couldn't speak certain words, how are you going to think, correctly? So that's why, I have to give this talk. But the resident is right. Hysteria definitely has disappeared. So to do research on this thing, So I went to medical library. There's no book, on the shelf on hysteria. And then I had to go to like Astrom Library, in the main campus. Anybody knows what this thing is in this picture? No, it's a robotic book retrieval system, okay? The book doesn't even stay on the shelf anymore, okay? You have to go to somebody, and then, so that shows you how obsolete, the concept is. So hysteria was removed from DSM-3 in 1980, okay? Reason being, it's not, so far we understand it's not an illness, and then it's definitely associated with male chauvinism. And then the last time any psychiatrist wrote on the topic is in 1980 by Philip Slavny. And then the book is Perspectives on Hysteria. So I'm quoting him here. He says, regarding hysteria, no term so vilified yet so popular, none so near extinction appears in better health. And so, brief history of hysteria. So in the ancient times, hysteria comes from the Greek word hysterikos, means uterus. So if you look at the history, all the famous physicians from Hippocrates down, they all wrote about hysteria. So at that time, Hippocrates, Plato, Galen, they wrote about hysteria. The main belief is the wandering wombs are causing medical problems by behaving like an animal within an animal. And so Galen recognized three types of hysterical symptoms in women. So episodes of losing consciousness, collapse from weakness, and breathing difficulty without losing consciousness, and contracture of limbs. So what's the treatment? So they believe, you can move the womb around. So if you put foul smells to their nose, you drive the womb down. And then if you rub frequent, good smells, in their private part, the womb will return to their original place. And then they believe sexual abstinence is causing problems, so the treatment is marriage and sexual intercourse. And then comes the Middle Age. So this book is called Malleus Maleficarum. So it was written by two Dominican monks in 1884 during Hispanic Inquisition. And then the English translation is Witch Hammer. So this is the manual on how to identify, persecute, and dispose witches. So they have their own, history of present illness, what they need. So you have to have a bad reputation, and then they have to present the evidence of the fact, and then there are always collateral information. You have to get witness testimony. And then there are also signs on how to identify witches. They call stigmata. And then so basically, if the subject is unable to shed tear, and then if they have a witch's patch, means the skin, the part of their body is insensitive to pain, and muscular contortion and convulsions. And then so what's their treatment? If you can call that treatment, basically they'll just burn you or kill you. So that's how they deal with this problem. All right. And then, so as society become more secular, and then the doctors, get more involved in this kind of business. So this doctor, his name is Edward Jordan, and then he wrote this book, A Brief Discourse of a Disease Called the Suffocation of the Mother. So that I think, one of the hysterical symptoms is, patients feel like they're being suffocated, and then because the uterus is moving upwards. And then so at that time, he believed the stigmata of hysteria was signs of mental illness. And then he also realized the diverse presentation of hysteria, and it links predominantly to female sex. And then he still believed uterus was a site of pathology. And then hysteria is through sympathy, uterus causes perturbation of the mind, which leads to hysteria. And then, so the struggle between, like secular society and religious society goes back and forth. And then the next one I want to talk about is Father Johann Gassner. So he's a very good exorcist. He's famous. He's really good at it. And then people come from everywhere to have him, drive out the ghost or observe him. And then so he would wave a crucifix over the possessed and then demand if the disease he was seeing has a preternature source, and the fact must be made manifest. So the patient would collapse into convulsion, and Gassner would proceed to exorcise the offending spirits. And I want to talk about Gassner because the next person, Franz Anton Mesmer, was at the same time as Father Gassner. So at that time, the society became more secular, and the city authority and medical profession start to complain about Gassner's public exorcism. And so a prince appointed a commission to investigate, and then Mesmer was a physician. He was invited as an expert to investigate Gassner. So in 1975, Gassner induced and stopped conversion in the subject without referring to the devils. And so after that, the church banned Father Gassner from doing public exorcism anymore. And so the historian Henry Ellenberg, said this made comments about this. He said it's not enough to cure the sick. You have to cure them with the methods accepted by the community. So Father Gassner, his method still works. And but somehow, the community, become more secular. They don't buy into hysteria anymore, so the church had to ban him. And then, Franz Anton Mesmer carried on, with what he learned from Father Gassner, and then he believed there is this thing called magnetic fluid or magnetic virtue. So it's either substance or fluid. It permeates the universe. It connects the heaven with human being, connects every human being. And then he believed he had special power to accumulate and channel the magnetic virtue to provoke and direct crisis so as to complete control them. So the thinking is, if I can induce something, and then I can treat it, I can make it go away. So what's a crisis at that time? So crisis believe it's a sign of latent disease, consists of swooning, convulsion, shaking, crying, and hysterical laughter. So with repeated provoking, crisis become less severe and finally disappear. So Mesmer would declare the patient was healed. And also the word report comes from Mesmer's practice. Report referred to, so he has to magnetize something, and then he has to get between that magnetized source and the patient, so he can get closer to the magnetic source, so he can treat the patient. And so I think it was Louis XV. He didn't like Mesmer, so he had the Royal Academy of Science to investigate him. And then Benjamin Franklin was involved. I think Benjamin Franklin is on the lower left side. And so they did the first blind and sham trials. And then so they have the mesmerist, to magnetize a tree, and then one of 4 trees. And then they blindfolded the child and then tell him, we're gonna, have you go under one of those magic trees. And then so as the kids, getting closer to the tree, he starts shaking. Eventually he develops seizure, but he was never near that tree, which was magnetized. And then so the committee says, basically Mesmer, the practice still work, but they discredit the mechanism by Mesmer. So, and then the final conclusion is imagination without the aid of magnetism can produce convulsion. Magnetism without imagination can produce nothing. Okay? And then so then comes Jean-Martin Charcot, the neurologist. So Charcot is referred to as the Napoleon of neurosis. At that time, neurosis means nervous system disease. Okay, it's not different concept from now. And then this is a picture he autographed and then gave it to Sigmund Freud, and then it's on display in Freud Museum in London. And so he got his MD in 1853, and in 1862 he became the superintendent of Le Salpêtre. In 1972 he was appointed the professor of pathological anatomy, and then in 1882 he became the chair of disease of the nervous system. That position was specially made for him. And then in 1885, Freud came shadow him for 4 months. And Charcot was very powerful. And then somebody says at that time, French medical school lived in the radiance of Charcot's great name, and under the despotism of this great figure, not a professor was nominated, not a hospital appointment made, not a gold medal given unless it was agreeable by Charcot. And then Charcot made huge contribution to medical practice. So there's a lot of things named after Charcot. There's Charcot's artery, Charcot's joint, Charcot's disease, Charcot-Marie Tooth disease, Charcot-Wilbrand syndrome, and a whole bunch of other things. And then Charcot also, cultivated a lot of famous students. So Sigmund Freud, Joseph Babinski, Pierre Janet, Pierre Marie, and George Gilles de la Tourette, and William James, just to name a few. And then how Charcot was able to accomplish this, because he developed new research technician, and then he developed new nomenclature for neurology, and then he has his own school of nervous study, and then he has a system to spread his message. So his research method is called anatomical clinical method. Basically, it correlates clinical symptoms with anatomical lesions. So he will gather extensive clinical observation of the patient during their lifetime, and once they pass away, he'll do autopsy, try to correlate the lesion, versus their symptoms. And then he also developed a new nomenclature for disease classification. Before Charcot, everything is weakness, spasm, and palsies. Charcot, come up with neuropathy, myopathy, myelopathy. And then he has a school for nervous system study, which is Le Salpêtre. And then he also has a system to spread his message. So he has his inner circle, his students, visitors, and then he gives lectures, and then he's in charge of a lot of journals. He published extensively. And then Charcot's a major contribution in neurology, including amyotrophies, locomotor ataxia, multiple sclerosis, Parkinson's disease. Charcot called it paralysis agitans, cerebral localization, spinal cord localization, and aphasia. And Charcot is also interested in functional dynamic nervous system disease without structural lesion identifiable at autopsy, so which includes epilepsy, migraines, and hysteria. And just wanted to give you one example how great a neurologist Charcot is. I want to talk about his contribution on ALS, which is also called Lou Gehrig disease. So before Charcot, all these related diseases was labeled as weakness. And then there's no correlation between pathology and clinical signs or symptom. And then at that time also, you want to remember the systematic neurological exam hasn't been developed yet. And then also there's no concept to differentiate between upper and lower motor neuron disease. So what Charcot did is he found the anterior horn degeneration in patients with infantile paralysis and muscle atrophy. And then there's another patient, initially she was diagnosed as with hysteria, and then Charcot found lateral spinal column degeneration with chronic progressive paralysis and contracture without muscle atrophy. So there's paralysis with muscle atrophy, and then paralysis without atrophy with contracture. And then Charcot also identified mixed case with anterior horn lesion and bilateral sclerosis of lateral spinal column. And then clinical weakness was accompanied by atrophy and contracture. So he was able to establish relationship between clinical signs and spinal cord lesions. And then to do this, he only need 5 cases. Okay, so that's and then but it's a very rare case, but it takes him 10 years, to accomplish that. And then so here comes down Charcot and Hysteria. So where he practiced is called Le Salpêtre. It's a hospice for women. And then so there is a psychiatric section and medical section. And then supposedly there's a 1,500 alienese, means crazy patient. And then there's roughly 3,000 patients in medical units. So the patient, they're all female, they just live there, and then they die there. So Charcot referred to that as a living pathological museum, okay? And then I think one thing Charcot failed to pay attention to is at one point one of the psychiatric unit was just too out of shape, so they moved those patients to the patient with epilepsy, and then that happened in 1870, and then after that, Charcot started to get into hysteria, and then so with Le Salpêtre, Charcot added laboratory, lecture halls, photography studio, museum, acute inpatient service, outpatient facility, hydrotherapy, electrotherapy, ophthalmology, clinical psychological service. He really expanded their service. And this is what Le Salpêtre looks right now. It's still a magnificent building. I think we all should go visit that place. And a lot of things happened at Le Salpêtre. So in 1792, there's this massacre of a mad woman over there. And in 1795, Philippe Pinel liberated mad woman, in Le Salpêtre. And in 1887, this is one of the clinical lessons given by Charcot over there. And so he was showcasing a patient with hand dystonia. And so I believe this guy is Joseph Babinski. This guy is Torres. And then the picture is about kind of who's who, in the neurological circle in Paris at that time. And then so what do you see in this picture? I'm sorry, somebody was murmuring. Can you speak a little bit louder? What? I'm sorry. Swooning. Okay. And then you see this tension between the male and female, isn't that right? So there's a couple of females on this side, and then all the guys are dressed in black, all right? And then they're all very serious guys. And then so this lady have a hand dystonia. She's doing this. What's in the far left corner? What do you see? What's that picture? So they have a they have a picture about a patient have a grand hysterical attack, okay? And then so Charcot's a clinical observation on hysteria. So he saw a lot of hemiparesis, hemianesthesia, tremors, dystonic posture, chorea, stereotypis, and then complex contortion. And then he realized the signs in hysteria closely resembles, but not exactly the same as signs in classical structure lesions. And then so the impairment usually is more intense and disabling in hysteria than classical structure lesions, and the symptoms were often intermittent, and then often precedes by a minor injury of the involved body parts, and then often resolved under hypnosis. So Charcot, because his expertise is this anatomical, clinical methods, so he's always trying to look for the lesion in hysteria. And then he couldn't find it, and then he referred to this as the sphinx of neurosis. So Charcot wondered, there's no doubt a lesion in nervous centers, but where is it situated, and what's its nature? So it's a question mark. And then so eventually he settled down. Hysteria is a neurological disease with a non-visible dynamic or functional lesion. And its clinical signs are comparable to structural lesion damaging the same brain area. And he believed his patient did not fake their hysterical symptoms. And then so if you couldn't find the pathological source of the disease, you're studying, so what can you do? So Charcot comes up, with a behavior characterization of a hysterical attack. So he basically says, so for all these grand hysterical attacks, it goes through the same stages. So the first stage is epileptoid. It's a tonic seizure, often precedes by an aura. In second stage, patient proceeds to contortion and acrobatic postures. Charcot calls it clownism. And then the third stage, there's emotional gesture and verbalization. In the final stage is delirium. So what does that remind you of? Does it remind you of the DSM? What we do these days? If you couldn't, find the pathological, so you just become very descriptive. You try to say, okay, if you do this, that's what I'm true. That's the diagnosis. And then this is one of the hysterical attacks. And so it's pretty elaborate, and pretty amazing. And my question is, what's the exposure time at that time, to take this picture? How long the patient have to, assume that position for the photo to develop? I couldn't figure that out. And then another thing, so Charcot also realized, the hysteria is definitely not limited to the female sex, and then male can have hysteric attack too. And then supposedly this is called arc and circle. So if you do this at Le Salpêtre, it's diagnostic. You're immediately labeled as a hysteria. Okay. And so Charcot moved on to hypnosis. So he believed, susceptibility to hypnosis is pathognomonic for hysteria. Means that's the pathology, that's the cause of hysteria. So because he observed hystericals are easily hypnotized in the trance, the physician can induce or remove hysterical signs by suggestion. Suggestions either come from the patient or come from the physician, play an important role in unleashing the dynamic lesions underlying hysteria. And then auto-suggestion by patients accounts for the self-perpetuating spells in hysteria. And then physician-induced suggestions in hypnosis could rekindle or remove the same hysterical symptoms. So the thinking is still the same. If you can induce this thing, and then you can remove this thing. So give you some sense of control. And Charcot's contemporary, they start to challenge Charcot's beliefs. So this is in the tabloid, it shows the death's head of suggestion is swallowing Charcot. And then also there's another school, it's from Nancy, and then they argue any suggestible patient could be hypnotized, not just the hystericals. And then so Charcot's problem is at the end of his life, he almost exclusively worked with his students. So he couldn't hear different opinion anymore. And also everybody need to write a thesis for their graduation. And then Charcot is so powerful, so everybody's writing about hysteria. And then the neurologists from other countries refer to Charcot's demonstration was a performance by the well-trained patients of Le Salpêtre. And then there's allegations, his resident colluded with the patient on how to perform and stuff. And then so the other neurologists believe, Charcot's demonstration, Charcot's result was being distorted by expectant attention. So the patient consciously, unconsciously knows what the doctor wants, and then they, give you what you want. And then so another thing is after Charcot's death, most of his students abandon his doctrine on hysteria. And then, so I want to talk a little bit the long-term outcome of all these hysterical patients. So at that time, there's quite a few famous, hysterical patients over there. So the first one is Augustine, and then she was raped. She grew up in a village. So at age 13, she was raped by her mother's lover. And then at age 15, she came to Le Salpêtre, and then she suffered from stomach pain, convulsion, and periodic paralysis. And then she was photographed repeatedly for Grand Hysteria. So this is her in the picture. And then she got better, and she worked as a nurse. And then she later on relapsed into frequent attack again. And then, so after that, she was treated with ether, chloroform, straitjackets, and confinement. Eventually, she escaped from Le Salpêtre disguised as a man. All right. And then this is Anna-O. So she was a subject in the book Studies on Hysteria, written by Breuer and Freud. And then so in her hysterical attacks, she couldn't speak German. She would speak a mixture of Yiddish, English, and French. And then she was analyzed by Breuer in 1882, and then supposedly she developed erotic transference to Breuer, so Breuer has to terminate the treatment. And then after that, she still had multiple relapse. Eventually, so she was admitted to institutions, and then eventually she became a feminist, and then she wrote books, and then she's fully recovered, after 1890. And so with my patient, I probably treated her like 4 or 5 times altogether, and right now she's on disability. Most recently, she was 6 months pregnant, and then she's 41 years old. In this admission, she did not have any pseudo-seizure or dissociative symptoms. She was depressed and anxious. She was mainly worried about her fetus. So we did ultrasound for her, show her, her baby is safe, and then we discharged her home. And so a lot of meanings was assigned to hysteria. So you see this dichotomy. So hysteria is referred to as a women's disease. So if you have female versus male, even though they have the same symptom, and then so in female it's always called hysteria. In male it was given different names like melancholy, hypochondria, neurasthenia, shell shock in World War I, and obsessional neurosis in psychoanalysis. And so there is a doctor in England. His name is George Cheney. He wrote this book, The English Malady, a treatise of nervous disease of all kinds, spleen, vapor, lowness of spirits, hypochondriacal, and hysterical distempers. So he claimed hysteria is a sign for English global superiority. And then he claimed if you're upper class, you're elite, your nervous system is really delicate, and then make you much easier to become hysterical. So he's trying to put a positive spin on hysteria. And then I think there's another doctor in America try to do the same thing around the same time. And so we have to talk about hysteria and feminism. So feminists, believe hysteria is a feminine proto-language. So they communicate through the body. Message cannot be verbalized. And also the thinking evolves to later they believe hysteria was the first step on the road of feminism. And then they refer hysteria as a daughter's disease against the ruling fathers. And they also believe the famous hysterias of the 19th century symbolize a universal female oppression. So this lady asks, what woman is not Doro? Doro is one of the hystericals patient analyzed by Freud. And but in medical practice, hysteria can be a very problematic diagnosis. So when doctors use that words, what do we mean? I think when I use that words, I mean her presentation is off the chart. Doesn't make much sense, in psychopathology. So in general, as doctors, when we say somebody is hysterical, we mean there's no organic disease. And then also patient may have like abnormal illness behavior. And but you can't say this to the face of your patient, and it will destroy your relationship with your patient. So David made the comments, hysteria is a diagnosis which cannot be made face to face with the sufferer, and then which condemn him to a lifetime of chronic non-recovery, if only to prove the doctor wrong. So he said this diagnosis is both ethically and then strategically wrong. And then also hysteria is very hard to diagnose. And so the key concepts such as secondary gain, labile indifference, over-dramatization, psychogenic precipitors are unreliable, not valid, and then doesn't have too much prognostic significance. And also the diagnostic criteria keep changing. And and then also doesn't address the things of clinical importance, such as patients' belief in disease. Sort of if they believe they have this disease, how should they present their symptoms? And then also, what's their attrition? Means, how do they blame this disease come about? And then how do they avoid to talk about this thing? And then also you go into this dichotomy between physical and psychological. So if it's physical, it's real, it deserves treatment. If it's psychological, it's unreal, it's undeserved of treatment. So it can be a very problematic, diagnosis. But hysteria experience, happens very commonly in daily life. So if anybody is stressed, traumatized, they can become dissociated for a while. And then in certain settings, like a religious ritual or healing practice, people do become, dissociated. They feel like they're being possessed, they're in a trance, but that's normal. That's socially sanctioned. And then also just in daily life, so we can have this trance in the highway if you're driving, and then the scenery doesn't change. It's very monotonous, 50 miles later, you're like, oh, what happened in the last, hour or so? So all these things, can be a normal process. And so they've been talking about the death of hysteria for a long time, and then they give out some reasons. First, the culture changed. So there used to be this sexual confinement, emotional oppression, and social suffocation, and then time changed. And also, they believe there's this enhanced psychological literacy. So Freudian concept become well known to the common society, and then people are more willingly to talk about their psychological struggle. But also, there is this drastic redefinition in hysteria medicine around 1900. So in organic medicine, you have change in diagnostic tasks or etiologies. So like for epilepsy, you can use EEG to make more accurate diagnosis. And then for syphilis, you can find the source, do your RPR and then make an accurate diagnosis. And then also in psychiatry, psychosis, become broader and broader. So there's concepts of catatonia, dementia precox, manic depressive psychosis. And then in the functional neurosis, there are different concepts. Janet's come up with psychasthenia, and Babinski come up with, he made up a word, it's called PCAtism, means suggestion and healing, and also Freud's psychoanalysis. And then my 2 cents is like the diagnostic criteria changed. And then because we've been doing checklist diagnosis, so there's no need to act out, in a hysterical fashion. If you could just come in and say, I'm depressed, I'm suicidal, and then it was taken at the face value, so why invest the extra effort? And then, so what's the mechanism of dissociation or hysteria? So I think this quote is really telling. So Paget says, the patient says, I cannot. It looks like I will not. But actually it's I cannot will. So hysteria, dissociation, this kind of stuff, it's a problem with patient's will. volition. So, of course, we have to talk about Freudian model. And then I think one of the contribution of Freud is basically when he started psychotherapy, he started with hypnosis. And then he was not too good with hypnosis. And then eventually he figured out without hypnosis, just by talking to your patient, patients are getting better. But if you look at the the history of hypnosis, start from Father Gassner, and then at Mesmer, and then Charcot and Freud, you see this kind of change. So when Father Gassner was doing it, he attributed his healing power to God. Okay, when Mesmer was doing it, he attributed to this magnetic fluid. And then Charcot would attribute it to this auto-suggestion or suggestion by physician. And then when Freud was doing it, he says, you don't need to hypnotize the patient. And then so there's two major concepts, Freud, brought up about hysteria. One is repression, so involving doing something to an unwelcome ideas that render it less conscious or separates from our primary consciousness. And then conversion operates as an excitation of the traumatic idea was converted into physical symptoms, so discharging its affective energy and helping to keep the idea repressed. So, but it's unclear how conversion happens, okay? And actually that's one of the main point when SARS started attacking psychiatry. He made the point, how can you tell me psychological symptoms turn into physical symptoms? And then so far, I don't think we have a good explanation. And then also the Freudian model become overreaching, and they have an explanation for every disease, and then any interpretation can be possible, and then the interpretation becoming increasingly complex and metaphorical. And the current belief is Pierre Janet probably got it right. So he believed hysteria is the mechanism is retraction of the field of consciousness, which leads to the loss of normal awareness of sensory input, and then drive the development of hysteria. And there's another doctor, his name is Krashmer, and then he provides this evolutionary perspective of hysteria. So he says there is, in general, if you watch animals, there's two types of response to threats. So this one is violent motor response. So it's like if you corner a bird, the bird just keep flapping the wings, frankly fighting. And then this kind of, resembles in human the convulsive dissociative seizure and violent tremors. Another is sham death response. So basically the animal just fake dead, becomes still without moving. And so it's related to, like in human, paralysis and fall down, laying still, and then this dissociative seizures. So he believed the initial trigger of this kind of behavior was by a traumatic event, and may be done deliberately to escape a difficult situation, but with repetition, it becomes more and more habituated and automatic, and the condition response no longer required the presence of inciting events. And then but I think there's definitely new progresses in the study. Since 2000 they did a lot of imaging study with functional neurological disorder. So this is the very first one. So it's done by Spence in 2000. And then they did PET study of functional paralysis. So they have three groups of patients. One is a conversion with arm paralysis, and then also they have actors tell them you just pretend you couldn't move, and then there are subjects who's normal, who's moving freely. And then they scan their brain, and then they see a difference. So the red region is where patient with hysterical motor symptoms, and they're like a hypoactivity, hypofunction relative to control. And then the green is the fakers. So they have a hypo function relative to control. So they somehow, different brain areas got lightened up. And so the current proposed mechanism for functional neurological disorder first thing, you have a dysfunction in your executive function, which is dorsolateral prefrontal cortex. And then also the subcortical area become more active. So there's abnormal function in limbic area. So the limbic activity got increased. And then also there's increased amygdala and supplementary motor area connection. And in addition to that, ventral media prefrontal cortex provide a effective context, and temporal parietal junction give a patient a sense they're not in control of their movement or lack of a movement. So that's the current understanding about what's going on in functional movement disorder. So far, I think we've been differentiating between psychoform disorder versus somatoform disorder. So if you have movement disorder, you lost touch, and then you go see neurologist. If you have amnesia, and then you have to come see the psychiatrist. So, but the question is, so neurologists, they can diagnose functional neurological disorder by their neurological exam, by their EEG, et cetera, et cetera. But what does psychiatry have to diagnose this kind of problem? And so, if anything, the answer is please don't do this, okay? So this.
Have you ever seriously considered?
This is a clip from Orange is New Black, okay? And so this lady is Pensataki, and in prison she was convinced by other inmates she has a special power to heal people, and because she had that power, she attacked a visitor to the prison, so she was put in the cage. So and then the forensic psychiatrist come to see her.
Suicide?
What are you, one of those hippy-dippy docs? Like if I told you I was dreaming about a pineapple, you would ask me if I want to have sex with my mama?
Have you experienced any of the following during the last 2 weeks? Anxiety?
Of course I've experienced anxiety. You think this is an easy job? Having to heal the whole world with just these 10 fingers? It's a lot of pressure.
Loss of appetite.
What does that have to do with anything? Doc. It's people like you that give America a bad name. Y'all go squawking around talking about guns being dangerous when all you want to do is shove pills down people's throats. When all they need is just a little bit of faith. Ask me about my appetite. Why? Because I'm just naturally kind of skinny.
Miss Doggett, if you could please just answer the question.
I have answered the question. I'm not crazy. I'm chosen. There's a difference. Now, if you just let me out of this cage, we can both get back to our jobs. Please?
You stated that you believe God is speaking to you and allowing you.
I don't have to believe, Doc. I know. Why don't you just go ask some of the other girls? They're all going to tell you. I've been healing ailments left and right. Miracle. There's proof.
These hallucinations you've been having.
I'm not having. I don't belong in here. Come on.
Miss Doggett.
I'm not a freaking animal. Get me out.
Miss Doggett, when you calm down, I will get you on a sedative, take you to a nice
I
room.
don't need any sedatives. Jesus has my back. Please. Doc. Doc. Come back.
Have you ever seriously considered?
All right, so I want to thank Kay Meyer and her husband for getting me this video clips. And so the question is, what kind of healer is Miss Doggett? So she's been healing people left and right, miracles. She's Mesmer, all right? All right. So, but through this interaction, what do you see? What do you see? So the psychiatrist is paying full attention to his clipboard, and then he just want to ask his questions. How's your appetite? And and then when I first watched this episode, I fell off my chair. It's just ridiculous. But I believe it happens every day. And so the checklist diagnosis, what's the problem with that? It gives the appearance of rational and impartial examination. And so Daniel Kahneman, he's this behavior, economics, and then he wrote a book. The title is Thinking Fast and Thinking Slow. So he believed as human beings, we understand the world through two systems, just metaphorically speaking. So system one is operating automatically and quickly with little no effort and no sense of voluntary control. And then system two, allocate attention to the effort for mental activity that demands it. The operation of system two are often associated with a subjective experience of agency, choice, and concentration. So give you a sense you're doing something. And then system one is most of the time are right. So system two usually just adopts suggestions by system one. System two is very, very lazy. And system two only take over when things get difficult. And usually system two at that point will make final decisions. But if you do checklist diagnosis, you basically rob the physician of their intuition. So I believe you can identify somebody who's depressed or psychosis if you just take a look at them, talk to them for a minute, okay? And then you don't have to go through all these checklists. But also if you don't use your system one, when would you use your system two? So I think both systems was robbed because if we practice like this. And then so what should we do as psychiatrists? So I hope I showed you long-term data with the hysterical patients. The first thing I want to emphasize, the long-term data always trump the cross-section data. Cross-section data, be it MRI or whatever, but those things are kind of not as telling as history, okay? And then the second thing is, the symptom is only meaningful in the background context. So without context, whatever checklist you're doing, it just doesn't mean anything. And then also we need to return to storytelling. That's how we understand the world. And then we really need to understand the sequence of events in patient's life and the sequence of events on the day of admission. And then you want to pay close attention to patient's affect and behavior, and then you want to acknowledge his suffering. So affect doesn't lie, okay? They can say, I'm suicidal with the biggest smile on their face, and then so you got your clue. And then also we need a better understanding of psychopathology. So by psychopathology, I'm talking about the concern. So psychopathology deal with abnormal experience, cognition, and behavior. There's in general two subtypes. So one is explanatory. So basically you start with a theory, and then you go out. And then the other type is very descriptive. So it's involved very close observation and phenomenology. And then so for descriptive psychopathology, it describes and categorizes the abnormal experience as recounted by the patient and observed in his behavior. Phenomenology go one step further. So you involves the observation and categorization of abnormal psychological events and the internal experience of the patient. So you have to use empathy, to get inside your patient's head, and then also his consequent behaviors. And then there's two concepts, I think it started by Jasper. It's very important in phenomenology. One is understanding, the other is explanation. So understanding means perception of meaningful connections. You can see meaningful connections in anything. And then explanation, it's a perception of causal connections. It's mainly involved in natural science. And it's kind of mechanical, and so that it has cause-effect relationship. So with our understanding, you need to remember, it's just interpretations. Anybody can give interpretations. And then also your interpretation is biased by your preconceived concepts. And then opposite interpretation are equally convincing. So some rock climbers, you can say, oh, he just enjoys climbing rocks. Oh, he has death wishes, that's why he's doing that. Oh, he's trying to conquer his death wishes, that's why he's doing that. And then also all the understanding are inconclusive. And then you can come up with as many understanding as possible. And then so basically I'm talking about, the models we should use in psychiatry. I think we've been using a medical model. So in medical model, you're treating a specific disease, there's a specific cause, and then specific pathophysiological process, okay? And then in the contextual model, basically you have a patient, you have a doctor, you have a milieu, you come together, you get treatment, and then you give them rationale while you're treating, and then you have your rapport with your patient, okay? And then so which model is right? Based on those two hypotheses, So there's this thing called absolute efficacy. So you compare treatment with no treatment. So in both cases, treatment is better than no treatment, okay? And then you can compare relative efficacy. You can compare treatment A, B, C. And then so if medical model is right, treatment A should be different from treatment B, different from treatment C. And then if contextual model is right, so it doesn't matter what you do, everything should be equally efficacious. So this is called the Dodover effect. So everybody are winners. You should all get prize. I think that shows up, in the study of the efficacy of psychotherapy. I think you see similar phenomena in psychopharmacology, especially when we use SSRI, SNRI, or something else to treat depression. They're equally efficacious. Doesn't matter what's the mechanism. And also, you can do a study. If you say, for this treatment, the specific effects is A, so you can do a treatment, give this treatment without the specific effects, and then you can see whether it works or not, okay? So if medical model is right, if you remove the specific effects, and then you're gonna, cause problem. The treatment will be less effective. And then if contextual model is right, if you remove the specific, the treatment, it should be the same. And then so general effects versus specific effects, if medical model is right, specific effects, should have a greater, effects than general effects, and then vice versa with contextual model. And then if medical model is right, there should be no difference between different physicians because you're giving the same medication. The medication, is more powerful than the physician. And then if contextual model is right, there is a difference between different treaters. Even though you're giving the same medication or different medication, somebody is more therapeutic or more efficacious compared to other physicians. So conclusion, hysteria is at the center of a history of medicine. It's also related to psychology, sociology, history, and literature. And then it's actually very important to understand the brain-mind relationship, okay? And hysteria is alive and well. I think I see them like maybe once a month, on my unit, okay? And then it's survived by just under different names: somatization disorder, PTSD, dissociative disorder, personality disorder. And Charcot and his students did not invent or eradicate hysteria, okay? And then so I just want to add with a couple quotes from Charcot. So he says the theory is well and good, but the phenomena exists anyway. Above all other things, clinical medicine is a study of the difficult aspects and the complexity of disease. When a patient calls on you, he's under no obligation to have a simple disease just to please you. He has every right to have a disease presenting as an extremely complex cases. So I want to give thanks to all the resident medical students, okay? You make my work a lot of fun. I really enjoy working with you guys, yeah. And so these are my references. Question? So I lost everybody, huh? All right. Yes, sir. Dizzy, yeah. Mm-hmm. Yeah, maybe, I think a couple of comments. One is, I think everybody prefer to have a physical problem rather than a psychological problem. And I think it is in the literature showing, so for people who are traumatized and then there's this blunt response to stress, okay? And then also if you look at their heart rate variability and when patients with hysteria problem are in recovery, the heart variability increase And then when they're in crisis, the heart variability goes down. So heart variability seems to be an index for the parasympathetic input. So that's at least current understanding about that. Yes, sir. Willfulness, yes. Yes, yes. So, yeah. Mhm. 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 Yes. Yes. Mhm. Sure. So, yeah. I, yeah, so they say, God heals the patient, doctor take credit. And so, yeah, yeah, that's what I do every day. That's what I do every day. Yeah, yeah. And so yeah, like you were saying, so a lot of things is out of our control, and then patients do get better, and then but somehow we all believe, we're that powerful. I'm causing changes. Yeah, Dr. Casey. Mm. Yes. I feel like, basically if you're doing surgery, it's a medical model. And then if you're doing psychiatry, I think it's more contextual model. But in psychiatry, if you're treating bipolar or schizophrenia, it's more a medical model. I think everything else, is kind of just a spectrum in between. That's how I see it. So we got to use both models, but sometimes, we sort of have this magic pill, we all have this magical beliefs. Mhm. Mhm. Yes. Yes. Dr. Lippman? Treats patient. Yeah. Yes. Yeah. So when I was in training, my mentor told me, when you see a patient, you got to think about access 2 first, and then access 1 comes second. But right now, we don't have access anymore. All right. Yes, sir.
voted on these checklists, these diagnoses or objectives, these set of objectives. And we have come to rely on lots of these kinds of checklists in various ways through trade examination, through scrutiny. And my view is that they play a legitimate role in the book review.
Mm-hmm.
But if you rely on those to the exclusion of narrative and understanding the person's context and meaning of what the symptoms have for a particular person, their family, their background,
Mm-hmm.
we're going to miss about 90% of the book.
Yes, you're absolutely right. You're absolutely right. Hi, Tegan.
When people see hysteria or panic stage, right, we already know that that's commonly in the United States. But taking carefully, you can see that patients may be taking those. So it's, especially in Eastern culture, I think still very common.
But yeah, I think with the disappearance of hysteria, and the neurology will contradict that, and then they will say they're all in my waiting room. Yeah, just change forms. I don't think it disappeared. Mm-hmm.
Even in my lifetime, the kinds of very sort of grand conversion symptoms, paralysis of the limb, loss of voice, something like that, we don't see those anymore. But there are many people that have complex or serious illness.
Sure. And then, yeah, and then also some neurologists are pretty dissatisfied with the current status. So they'll say the diagnostic criteria for conversion was made by psychiatrists and then used by neurologists. And then the psychiatrists don't see the conversion patient anymore. Why do you guys, keep making the diagnostic criteria? All right. Thank you.
I couldn't find it in my,
Oh, you can?
so I'll just, because, it's limited in there.
Oh, yeah. KFC, there it is. For the residents, yeah. It'll be like 5 people. Next week? Sure. When more residents are there? Okay.
Oh. Okay.
Never mind.
I was nervous for nothing.